This is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with a cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Good morning. Good morning. I hope you can hear me. Good morning. Good mornings. Welcome, everybody. Thank you for joining us this morning, and welcome to August. Who can believe it? It's already the 8th month of the year. So yeah, that's amazing to see that we've all gathered today. This Caribbean African Health Net, you have more options than you think. So my name is Dr. Onyi Okonkwo, and I am a GP in Birmingham. I am also a trustee of the Royal College of General Practitioners. It would be wonderful to know where everybody's dialing in from. So if you can, would you mind putting in where you're dialing in from in the chat so that we can recognize where you're dialing in from? Oh, wonderful, Nika. Lovely to meet you. Good to see you're from Birmingham as well. Remember, everybody, no matter where you're dialing in from, it's summer. Make sure you stay hydrated and use your sunscreen. I know, yeah, a lot of times we don't think we need sunscreen, but as your resident GP this morning, I will encourage you to use your sunscreen at least factor 30. So today, like I said, we have a wonderful, wonderful, exciting hour lined up for you on fibroids, because we are just closing out the month of, of fibroid awareness. So the whole of July was dedicated to fibroid awareness. So who else but the lovely and wonderful Dr. Miss Natalie Nunes to come and talk to us about it today. If you don't know Natalie, then honestly, you need to log in more to these sessions, because last week she was hosting the session. She is a consultant gynecologist. She has over 25 years of experience, and she specializes in early pregnancy care. I actually met Natalie at the last Cannes Awards ceremony, where she was being highly commended for her health innovation and systems leadership, and she was absolutely brilliant. And if you remember, last year, 2025, Natalie also won the Women Health Practitioner of the Year award. So she is an absolute powerhouse. She provides compassionate and evidence-based management of miscarriages, ectopic pregnancies, and complex early pregnancy conditions. She's a recognized innovator. She introduced virtual reality headsets to help reduce the pain and anxiety that you feel when you're having your miscarriage procedures. And she's been combining empathy with technology to improve all our experiences as women. And you can see her absolute commitment to transforming women's care. So, Natalie, over to you. And we're also excited to hear from you this morning.
Wow, thank you so much for that very, very warm welcome. Thank you very much. Okay, everyone, so glad to see you guys here. I am going to share my slides now, and there we go. All right, great. So, I am going to be talking about fibroids, but I'm going to be focusing on the incision-less options for treatment of fibroids. So I don't need to tell you who I am, because we've had such a warm welcome. So I I will skip this slide just to say that I do have over 25 years in working in healthcare and in gynecology. All right, options, 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 options. I am such, um, I'm very passionate about options and that women need to be given all their options. If you go to a gynecologist and they don't tell you about every single option and then tell you which one is suitable for you and which one is not suitable for you, then they are doing you a disservice. Okay? So I'm giving you this information so when you go or when your partner goes, your wife goes, your sister, your daughter, they know the options already so that they can then discuss it with their doctor. So, first line is pharmaceuticals or hormone therapy. And these don't treat the fibroids specifically. What they treat are the symptoms. So this tranexamic acid reduces the heaviness of the bleeding, mefenamic acid reduces the pain, then hormonal therapies can also reduce the bleeding, but they don't address the fibroids themselves. So they tend to be a little bit of a holding space until you have something more definitive or until you're ready to conceive. Then we have radiofrequency ablation, and the one that I use is Sonata. So Sonata transcervical fibroid ablation. And I'm going to give you a lot more information about that later on in this talk. Then we've got hysteroscopic myomectomy, and these can sometimes be quite big words, but basically you're going through the vagina, through the neck of the womb, into the uterus to then cut away the fibroid that's bulging into the cavity. Then we've got embolization. It goes through an artery in your leg, at the top of your leg, to put off some pellets to block off the blood supply to the fibroids and to the uterus. Then we have myomectomy, and this could be laparoscopic, this can be open. Um, Laparoscopic radiofrequency ablation is not available in the UK, but at laparoscopy, we can remove the fibroid surgically. And then we do have hysterectomy. So, the most important thing you need to understand about fibroids is where they are located. It's not just about the number and the size. Those are important, but where they are is so important to help you determine which treatment option is best for you. So I think of the uterus of like a balloon, and a fibroid can bulge into the balloon, like you see in this picture here, or it can bulge outside, or it can stay within the wall. So this diagram on the right-hand side, you can see that the fibroids are graded according to how much it bulges into the cavity and how much of it, in terms of percentages, is left within the wall. So a type 0 is completely bulging into the cavity. It's on a stalk. It's like a grape or a cherry. So it's completely attached only by a little stalk. A type 1 is where most of it is bulging into the cavity. A type 2 is less than half of it is bulging into the cavity. And those are the submucous types. Then we have the intramural types. That's the type 3 and 4. And a 3 is in the wall but touching the lining of the womb. And a 4 is in the wall but not touching the lining of the womb. And then we've got 5 and 6 and 7. And these are like 0, 1, and 2, but they bulge in the other direction. So 5, less than half is bulging outside. 6, more than half is bulging outside. 7, it's on a stalk, like that cherry once again. So it can move, it can slide. And 8 is any other location, like the neck of the womb, which is the cervix, or the broad ligament, which is a ligament on the side of the uterus. So I hope that's clear about where the location is of the fibroids. Great. So Black women and fibroids. Khan does so much work for us. This was a document published with the Professor Ruddock. This asked women across the country about their experience of fibroids, looking at our women. We know that fibroids are more common in Black women. We have a greater number of fibroids. It occurs earlier in life than women of other races. They tend to be larger in size. they're more likely to recur. So you can have them removed and quite quickly they can come back. And in the document from the woman, this is what our woman, said in our country. They had diagnostic delays, often more than 2 years. There's dismissal and minimization of pain, limited access to fertility preserving and minimally invasive treatments. And those are the ones I want to really talk about today. There is an over-reliance on hysterectomy. Oh my gosh. Just because your doctor thinks they're going to struggle to give you something more minimally invasive and a hysterectomy is easier for them does not mean that you need to accept that. And there's significant emotional, psychological, fertility, and economic impacts. And this document is fantastic. It has given that evidence to those with the power, and hopefully we are beginning to see some changes. So the first one is a hysteroscopic myomectomy or hysteroscopic resection of fibroids. So how is this done? So a thin probe is guided into the uterus from outside through the vagina into the uterus. There's a camera, there's a light, there is fluid that inflates the cavity, and it allows us to see where the fibroid is, whether it's a 0, 1, 2, bulging into the cavity, and then cut it away. There are two ways we can cut it away. It could just be with a small blade that cuts it away and sucks the fluid out. That's called a tissue removal system. And then electrosurgical uses the blade, but also some energy. And it's really important to know what type of fibroid you have so you know whether this is a suitable option for you. And then the size to see whether they would be able to cut it all away in one go. So, why is fibroid location so important? Well, the submucosal types 0, 1, and 2, as well as the 2 to 5, those are the ones that bulge into the womb cavity, and they have the greatest impact on heavy bleeding and fertility. They are the ones where they can be 5 millimeters, 1 centimeter, and they will cause significant bleeding. Whereas a 1 centimeter subserosal fibroid, you wouldn't know you had it based on symptoms. Intramural also can cause an effect on bleeding, pressure, and fertility, but they tend to get a little bit larger before they begin to give you those symptoms. And a subserosal ones, the ones that bulge outside, tend to cause more pressure symptoms. Pressure on the bladder, making you need to go to the toilet more often, pressure on the bowel, causing constipation, pressure on the top of the vagina, causing pain with intercourse. So where your fibroid is really, really important. So submucosal fibroids and fertility. I want to protect the fertility of our woman. So it's really important because submucosal fibroids cause a 63% lower chance of pregnancy and a 68% higher risk of miscarriage. So it's harder to get pregnant. And then when you do get pregnant, there's a greater risk of miscarriage. And what is really fantastic about this data is that we also know that if you remove that submucosal fibroid, that you double the chance of pregnancy. So that is so treatable. And that's where the hysteroscopic resection comes in. So the risks, everything has risks, but the overall complication rate is low. It's well under 2%. Perforation, making a hole through the womb, small risk, but the womb often heals because it's made of muscle fibers. So the muscle fibers will just seal the hole back as long as nothing outside of the womb has been damaged. Heavier bleeding, we can manage that. Fluid-related complications can happen. You can absorb too much fluid, which essentially dilutes your blood and therefore affects your electrolytes. So we have a certain amount we will allow you to absorb, and then we would need to stop the procedure. Scar tissue, anything that cuts can cause scar tissue. With a hysteroscopic resection, the scar tissue can be inside of the womb, which can then impact fertility in terms of implantation or make periods lighter. So we have some things that we can do to try and reduce the risk of scar tissue on the inside of the womb. And sometimes not all the fibroids can be removed at that point in time. And that would be because the part that's still inside of the wall can't be reached, or you've absorbed too much fluid and we need to stop the procedure. So sometimes a repeat procedure is needed, or if you double up the procedure with a Sonata radiofrequency ablation, we can ablate the part that's within the wall so that it shrinks in the wall and doesn't then protrude into the cavity. So, how will this affect my fertility? Well, because it goes through the vagina and the cervix rather than cutting through the wall of the uterus, you don't get scar tissue in the abdomen, in the tummy, on the outside of the uterus. So there's no added risk of a rupture to the womb, which can happen with myomectomy. Vaginal birth is still possible, good chance of conceiving afterwards, and the scar tissue is the main watch point in terms of the scar tissue on the inside of the uterus. So, summary of this evidence. It's done through the vagina, through the cervix, so that's transcervical, benefits heavy periods and fertility, and to the pregnancies. So it's a triple win. Low complication rates, but it's only suitable for the submucous fibroids. That's 0, 1, and 2. Now I'm going to talk about embolization. So how is this one done? A tiny catheter is inserted into an artery. It's usually at the groin, but it can be in the wrist or elbow. It's done under local anesthetic. So there are no cuts to the womb. It's guided through the blood vessels to the arteries that supply the womb, using X-ray imaging to check the position. And then little pellets are released to block off the blood supply to the uterus and to the fibroids. Now, the aim is to cause the fibroids to shrink, but it is affecting the uterus itself. So there are pros and cons and complications that we will discuss. So what are the risks? Catheter site issues, so bruising, bleeding, infection, small risk. Post-embolization syndrome. When you embolize or block off the blood supply to the uterus, the tissue dies a little bit, and it's a type of dying that's called ischemic necrosis. And ischemic necrosis is like a heart attack. You know, the pain of a heart attack is ischemia. This is ischemia in the uterus, and it can be quite painful. And so good pain relief is given. You can have a mild fever, nausea. Sometimes patients are readmitted because of it. It's quite a challenging post-procedure situation that we manage. You can pass small pieces of fibroids. That's not so concerning. Small risk of infection, 1 to 4%, and particularly more so with the fibroids that are bulging into the cavity. What is really important to know is that there's a small risk of an early menopause, and that's really important. And that's more likely to women who are over the age of 40. And that's because some of the blood supply to the ovary overlaps with some of the blood supply to the uterus. And so when we're putting the blood supply to the uterus, some of those pellets can affect the ovary. So that's really important if you're doing this with a view to fertility. The other thing to note about the risks is that there is an increased risk of miscarriage as well, and that is because it affects the muscle of the uterus as well as the fibroid. And the muscle of the uterus is also important with contractility for the purpose of fertility. So what if I want to have a baby after? Well, fertility rates, getting pregnant, the rate is about 50% as opposed to 78% after myomectomy. So we tend to only use this for somebody who no longer wants to conceive, or their fibroids are too large for any of the other minimally invasive options. Miscarriage rate, I've mentioned, it's higher risk of miscarriage. Live birth rate is less, preterm birth is more common. And that's because it's affecting the muscle of the womb as well. But this is something you still need to discuss with your provider because it may be something that you want to consider. So in summary, it goes through an artery in the thigh or the arm. It causes a reduction of the fibroid of about 50% by volume, painful during and after the procedure, but it's safe, it's incisionless, it's done as an outpatient or day case. You don't need a general anesthetic for this, but there is an increased risk of miscarriage, increased risk of preterm birth, and increased risk of an early menopause. Now I'm going to talk about Sonata radiofrequency ablation. So what is radiofrequency ablation? Well, it's a minimally invasive procedure that uses radiofrequency energy to generate heat, and the heat is targeted only inside of the fibroid, not inside of the muscle of the uterus. And that heat causes a different type of necrosis. It causes coagulative necrosis, not as painful at all. And what it does is it almost kind of dries out the cells. And so some of the cells die because of the fluid gone from inside of the cells. The healthy part of your womb is left and it is untouched. So how is it done? So a thin probe is guided into the fibroid. So with Sonata, there's a tiny ultrasound probe that goes inside of the uterus and allows you to look around the womb exactly where the fibroids are. And then the probe is put into the fibroid along with some further arrays that creates this volume, a volumetric assessment. There's a smart guide on the ultrasound showing these red and green circles, which allows you to target the fibroid itself. The fibroid shrinks over the coming months. We get greater shrinkage, 70% by volume, and symptoms reduce, quality of life improves, and your womb heals with no scars. No scars. There was a study that looked to see, do we get any scars on the inside of the uterus? No. Do we get any scars on the outside of the uterus? No. So that's one of the really good benefits about Sonata. So this is a really quick video. So diathermy pads go on your legs. The ultrasound probe goes inside of the uterus, allows you to look around the entire uterus. You spot where the fibroid is. You go close to it. You adjust the ultrasound tip a little bit away, and then a needle can go into the fibroid while continuously looking at it on the ultrasound screen, which is down here. So this is what you're seeing on the ultrasound screen. You can make the circles bigger, you can make them smaller, to make sure that you are having it directly over the fibroid. You want to make sure the green zone does not go outside of the uterus. Then you advance the needle, then you advance the further array is what we call it. And you make sure you've got a safety zone, you generate the heat, and then that fibroid is treated. And then you come out and you look around for the next fibroid to treat. So why do women choose this option? No cut, no incision, no scar. So there's nothing to heal on the outside, nothing to heal on the inside. It's all within the fibroid shrinking. It can be done as a day case or an awake procedure. So this can be done under local anesthetic, under a gas that we use called Penthrox. You go home the same day. There's no hospital stay. 50% of women are back to normal activities the next day. The rest of the women just need a couple of days. So really, really good recovery. You can treat many sizes. We can treat from as small as 1.5 centimeters to 8 centimeters. And this is so important because some of our other options, for example, a myomectomy, goes for the bigger fibroids and does not necessarily remove the smaller fibroids, which then grow and become a problem in a year, 2 years, 3 years. You can treat several fibroids at once, and you can treat several types of fibroids. So not just the submucosal ones, not just the intramural ones, not just the subserosal ones. We can treat all the types. The only types we can't treat are the ones on a stalk, like the cherries. The cherries on the inside, the cherries on the outside. We cannot treat those. Why else? Well, it's targeted, it's ultrasound guided, it's not treating the whole uterus, it's not causing ischemia of the whole uterus. We see the improvement at 3 months, which is really good. So we use a standardized, validated fibroid questionnaire. It looks not only at symptoms like how much is your bleeding, but it looks at quality of life, like do you need to put a sheet on your bed because you're worried about soiling your clothes? Do you walk with a change of clothes because you're not sure if your period is coming that day? And we see such a marked improvement at the 3 month mark. I will show you that later. Quick recovery, I've mentioned reduction in bleeding. 95% of women had less menstrual bleeding. The fibroid shrinkage, 70% by volume by the 12-month mark. And there are fewer complications because we're not going into the abdomen. I've mentioned that there are no scars. So, what about in the UK? Well, we published this last year, and this is the largest study in the UK. And this was between Manchester and myself. 70% of our patients were awake. The pain score was 3 out of 10 on average, which says to me that we are addressing women's pain. We are going against the medical misogyny of saying that women don't feel pain. We are giving options. And the 30% who felt they would not cope with it awake, they had it under general anesthetic. And this is a graph. And what you're seeing, the red one is that symptoms halved by the 3 month mark and then remained low. And the quality of life, it doubled. So it went up by 100% and then maintained. And this is such an impactful graph for me because it's showing me that I am giving benefit to the patients that I treat. In terms of complications or risks, very small, less than 2% were readmitted. One patient had an infection. One patient had a hole made in her womb, but not with the sonata. It was during the dilatation, which is opening the neck of the womb. And in that case, she was still able to have her procedure. She didn't need anything further, had some antibiotics, the womb healed, and she was absolutely fine. And this was my data specifically. So I've done 240 patients. So I've actually done the most number of Sonata procedures in the United Kingdom. And this was my specific data. So you still see that improvement at that 3 months, continuing to improve over the 12 months. And then I wanted to look at not just the overall. I wanted to know specifically what things was I helping. And so heavy menstrual bleeding was the highest thing to improve. And that's usually what women come to me about. But there was also an improvement in fatigue and tiredness. So hemoglobin counts were maintained, they weren't tired and fatigued, pelvic pressure improved, anxiety. So yes, it helped with anxiety about periods, social activities interference, exercise limitation. You didn't have to plan your gym going around whether you were on your period or not, and soiling concerns was also improved. So, what if I want to have a baby after? Well, 74% in a study, a small study, 74% of women did conceive in the next year. And this is a very small study. So we really do need more studies. We need more data looking at conception after treatment. But miscarriages, we had a lot more data about miscarriages, and there was no increased risk of miscarriage. In fact, it was slightly lower. And in terms of getting to full term, normal size baby, there were no stillbirths, there was definitely no uterine ruptures, there were no placentas that attached abnormally to the inside of the womb after the treatment. Those were all normal. So, radiofrequency ablation can be done transcervically, transvaginally, or laparoscopically. But in the UK, we do it transcervically and transvaginally, and I do the transcervical route because it allows me to get closer. So I go through the cervix and I don't go just from the vagina. Volumetric reduction, 70%. Symptom improvement at 3 months, which is really important. Significant improvement in quality of life. Reintervention rates were 7% for Sonata, up to 15% with some of the other technologies. And this is over the next 3 to 5 years, whether you would need another procedure for your fibroids. Fertility numbers were small but favorable. It's safe. It's incisionless. It can be done in the outpatient or day surgery. Go home the same day. Really quick recovery. Really important. Treats the fibroids when they're small, before they become too large, before you need the larger procedures, the larger operations. The Royal for a group of us at the Royal College and the British Society for minimally invasive procedures. We are both working towards looking at better education for patients, GPs, gynecologists, better whether there should be a screening program, whether Black women, especially those with a family history, should be, without having any symptoms, get an ultrasound scan, maybe at age 25, to look and see, do you have any smaller fibroids? Can we treat those before they become too large? So we're working on this, especially with Khan's help. We can treat the fibroids before they're too large, and I think that's really, really important. It can be combined with the hysteroscopic fibroid resection. So we go into the uterus, we treat the fibroid to shrink it, but also we cut away the part that's inside of the uterus. And that works really, really, really well. Thank you. I've also I'm going to take questions, but before I jump into the questions, I'm just going to play this video. This was my patient, and she's going to tell you about her experience.
My name's Michelle Sultan. I'm a freelance hairstylist. I'm 45 years old and I'm a mum. My fibroid journey began when I started experiencing really heavy periods, heavy clotting, and general discomfort, a lot of pain, and feeling very low, very tired and exhausted. And I just noticed my periods were getting really heavy and lasting for much longer periods of time. I was just always aware that, you know, I'd get up from a chair and get up very cautiously and have to look round. I wouldn't sit on light-coloured chairs ever. It just was such a heavy burden. I took it upon myself to go to my GP, who sort of said, oh no, you're fine, without doing any checks. So then I took it upon myself to go to a private gynecologist. She said, well, your iron's really low. I need you to go to a hospital and get an iron transfusion. We've discovered that you've got a fibroid. I had a few more episodes where I was going in for iron transfusions, which were in turn like just ending up in A&E and, you know, just having horrible, horrible episodes. And I went and had scans, various other tests, which then they offered me a myomectomy. They said they would need to do more checks and I'd need to wait a little bit longer, which I did. I first heard about the Sonata treatment after going in to see a lovely consultant who told me about the treatment. I explained to her what my job was, you know, the fact I wouldn't have a lot of time for downtime. And she said, hold on a minute, there's a treatment that's available. Your fibroid would be perfect, the size of it. And the actual treatment itself was just such a calm, lovely experience. So my partner was able to come in the room with me. The lights were dimmed. My consultant played some lovely music and she kept on saying, you're okay, you're going to be all right. And she was holding my hands and I'm getting tearful. But no, it was cool. After the treatment, I went straight home. Yeah, I just had a good night's sleep basically and woke up in the morning and, you know, just took it easy for about 24 hours, 48 hours. And then I think by day 3 to go back to work. So life after Sonata is incredible. I wasn't tired. I didn't feel run down. Periods are, you know, normal, whatever normal is. Not having to worry about things like that. Such a relief. I cannot tell you. So yeah, no, it's really life-changing. I just feel like I've got my life back. I feel like I can get on with my day. I just feel like me again.
This testimonial reflects the real-life experience of the patient. In a clinical study, 86% of patients reported an average of 40% reduction in heavy menstrual bleeding at 3 months. Common side effects may include bleeding.
I will stop there. I've told you the side effects already. So, I hope that was clear. And if anybody has any questions, I'm ready to answer them.
Right. Wow. Natalie, that was amazing. Even as a GP, I've learned so much now that, I am going to be able to advocate for my patients a bit better because, quite frankly, yeah, you've completely blown my mind. So, thank you so much for that. And I would only apologize, on behalf of all of us because, quite frankly, we've normalized fibroids, haven't
Yeah.
we? We've made it a fact of life for us
Mm.
African and Caribbean women. We just kind of get on with it. We say to everybody, oh yes, it's very common with us, but what exactly are we doing for it? And I'm so thankful to you and your colleagues who are advocating for us to actually do something about
Yeah.
it,
Yeah.
especially if people are young and they have smaller fibroids. Honestly, that has been, if I took anything away from your talk, that for me was such an eye opener. So I have lots and lots of questions for you.
Okay.
The first one was from Medina. Medina wants to know, how does body weight impact on the options for treatment? Because she's been told by her gynecologist that she needs to lose a significant amount of weight before they can treat her. So is there an option that is better for people like her?
That's a really good question. And your gynecologist is probably thinking about doing a myomectomy or a laparoscopic myomectomy. So, because going into the abdomen, going into your tummy, if you are overweight or of a larger weight, your complication risk is higher. So under general anesthetic, your complication risk is higher when they're managing your airway. Also, wound infection is higher. Surgically, it's more difficult for the surgeon. But the minimally invasive options, it doesn't matter. So hysteroscopic resection doesn't matter your weight. Sonata, it doesn't matter your weight. And embolization, I would wager that it doesn't matter either because the arteries, we can feel where they are. We can find your arteries. We can get into your veins. We can get into your arteries. So it wouldn't matter. So it could be that your fibroids are of a size that they think the best option is a myomectomy, or a hysterectomy or whatever going through the abdomen. And that is where weight does play a role.
Thank you. Thank you, Natalie, for that. So, Medina, you now know you have options, like we've been
Options,
told.
yes.
Yes, lots and lots of options. Right. So, Annabelle would like to know, do fibroids get worse during the perimenopause, particularly when they are very large? And what would be the treatment options at that time?
Yeah. So the fibroids themselves don't get worse, but the combination of the fibroids as well as the perimenopausal symptoms is probably what you are talking about or describing. So, for example, the fibroids will make the periods heavier, more painful,
Mm,
and those sorts of symptoms, but perimenopause will make the periods or can make the periods irregular. So, if you're having irregular and heavy periods, that's just horrific.
yeah.
And that's just, more than anyone should have to deal with. So it's not that the fibroids get worse, it's just that the perimenopausal symptoms of irregular periods, fluctuations in the hormones can add irregularity of bleeding on top of the symptoms. And the options are the same. Don't let them tell you because you're perimenopausal, it has to be a hysterectomy. It does not. The options are the same, depending on the location, depending on the size, all of the options are the same.
Thank you, Natalie. Then Dillis would like to know, is there a link between the Sonata treatment and people developing adenomyosis?
There is no link between the Sonata treatment and developing adenomyosis. Adenomyosis is a condition where tissue like the lining of the womb gets into the muscle of the womb. And that is like endometriosis, how the lining of the womb can get outside of the womb completely. And there is no connection by the needle going through the lining of the womb into the fibroid does not cause adenomyosis. You probably already had adenomyosis. And when you think about adenomyosis and endometriosis and fibroids and pretty much every condition, it starts quite microscopically. It starts as one cell. Fibroid is a growth of a muscle cell, and adenomyosis or endometriosis is growth of endometrial-like tissue. So it may not have been recognized before, or it may have gotten worse over time because adenomyosis tends to get worse with time. But the sonata would not have caused it.
Thank you for that. And then Keisha would like to know, and to be honest, I'd like to know as well, is sonata treatment just privately done?
No, it is not. And so it is available in the NHS. Not every hospital has it, unfortunately. But it is rolling. I think it's in about 35 hospitals across the UK on the NHS. And so you might just have to do some research about where it is available. Some hospitals started and then have stopped temporarily because of some changing in funding by NHS England, which we are working on. But some other hospitals have started, some others still have it. Some have it, but only under local. Some have it local or only GA, under general anesthetic. So it is available on the NHS, absolutely. You can search, you can even contact the Sonata company. They know which hospitals on the NHS have it, so they can tell you which is your closest hospital or closest clinician who can provide that for you.
Sounds like Sonata Company is going to be very busy after this talk. So, someone using a Samsung phone, thank you, Natalie, for that answer, actually. Someone using a Samsung phone is asking about fibroids that are about 15 centimeters. For people that want to preserve their fertility, what treatment options do they have if their fibroids are that big?
Yeah. So that's a really big one. And that is, that is absolutely a more challenging one to treat. Um, if you want to maintain your fertility and you've not had any operations before, or you've had maybe one abdominal operation before, if you want to maintain your fertility, I think a myomectomy is the better option for you. That can be done laparoscopic, even at 15 centimeters. There are some surgeons who have the skills to do that size for you. Um, or it can be done open, though open, the cesarean section cut or midline cut has more adhesions or scar tissue on the inside than keyhole operation, which is laparoscopic. But overall, a myomectomy will give you the better chances of conceiving after and carrying the pregnancy to term. If you've had, occasionally we have women who've had a couple of myomectomies already, they've got a lot of scar tissue inside, and there aren't any surgeons who feel safe to go into the abdomen in order to remove your fibroids, then they may recommend embolization at that size. Now, we know that there would be a slightly increased risk of um, miscarriage, lower risk of getting pregnant, um, preterm labor, but it would still be an option versus nothing. And so you'd have to balance those risks for you and what you want. So if someone can do a myomectomy for you, that would be the best option in terms of conceiving after.
Thank you, Natalie, for that. Okay, Amelia would like to know. She said she's suffering from extreme fatigue, but when she asked her GP, they said the fibroids don't cause fatigue. So how can she get rid of that? Is it only through surgery? Because she says she eats healthy, she exercises, and she's taking iron tablets.
Okay. They do cause fatigue. They do cause fatigue. And I'm sorry that your GP does not believe you. So the first thing would be to know where your hemoglobin and your ferritin are at, because you can have a normal hemoglobin because you're taking the iron, but your iron stores are still low, and that can still cause fatigue even if your hemoglobin is normal.
Mm.
So you need to ask your GP to not just check your hemoglobin, but to check your ferritin
Very.
levels. And if your ferritin levels are low, then there is the option of an iron transfusion to bump it up and give you that and make you feel better and less fatigued. Um, and in terms of the fibroids, there are the options that I've mentioned, the minimally invasive options, avoiding surgery, whether it's where they are located in terms of do they need to be cut away from the inside? Can radiofrequency ablation shrink it for you to improve your quality of life? That's so, so important. But the other thing is there are other things that can cause fatigue. What is your vitamin D levels like? Women of color struggle to absorb and create their own vitamin D with the sunlight. We should all be on vitamin D. And if you have
Absolutely,
fibroids,
absolutely.
you definitely need to be on vitamin D. So and then on top of that, we've already heard about our sunblock. So we need to protect our skin, but we need vitamin D. So we should all be on supplements. I hope everyone is taking their vitamin D supplements. But low vitamin D can also make you feel tired and fatigued. So if your GP is saying they don't think it's your iron, then okay, ask them, have you checked my ferritin levels? Have you checked any other blood tests? What is my vitamin D like? How is my B12? There are all sorts of things that can contribute, and so they can do a workup for you. And remind me, Dr. Konora, that new rule about if you've been to your GP 3 times about
Yeah,
something,
yeah,
is it
yeah.
Martha's?
Just like, yeah, I think it's Martha's. There's one that is a hospital one, and then there's
Yes,
one that is the
exactly.
general practice one. But
Exactly.
whichever one it is, if you've been 3 times, ask for somebody else. I'm actually quite surprised that your GP hasn't done all the things Natalie's talking about, because usually I think if I count how many times I do blood tests, tired all the time is one of the ones I do loads and loads of, because you've got to look at the thyroid, you have to look at the
Yeah.
blood count, you have to look at the ferritin, you have to look at so many B12, folate, you have to look at their vitamin D. And can I add to Natalie's point? 800 units of vitamin D. Public health says all of us adults should be on 800 units of vitamin D, and children 400 units of vitamin D. So if you're not taking it, go and buy it over the counter, please, because everybody's been asked to take it. We don't prescribe it. We encourage you to go and buy it. So please, please, and when you go, make sure 800 international units for an adult and 400 for a child. Very important. But it sounds like there is a theme coming out from today, isn't it, Natalie? We need to
Mhm.
advocate for
Yeah.
ourselves sometimes so that
Yeah.
our voices are heard. Okay, I'm going to move quickly because we have so many questions.
Okay.
Achine wants to know, is Sonata suitable for women with submucosal fibroids who also have adenomyosis?
Yes, absolutely.
Okay,
Usually with a submucosal fibroid, um, we may suggest also resecting the part that's in the cavity. But if it's just a type 2 and there's only a tiny bit inside of the cavity, you don't need to resect. You can just do Sonata. And we are beginning to do Sonata for adenomyosis. Um, and we're trying to see is there any benefit? We are seeing some benefit, probably not quite as much benefit as to fibroids. But yes, you can still have Sonata for that.
fabulous. And if Olua wants to know, is there a maximum size of
Mm.
fibroids that Sonata can handle?
Yes. There is a maximum size. So the ablation zone is about 5 centimeters, but we can treat up to about 9 centimeters. And that's because if you have a cherry, you can just pop it off into your mouth and take it in one go. So a small fibroid, you can just take in one go. If it's a little bit bigger, like an apple, you take bites of the apple, as long as you can reach it. If a fibroid is too large, we can't reach it we can't reach the outer part of it to treat it. So we can treat up to about an 8 to 9 centimeters. When I have women who have like 10, 11, 12, and everything else is suitable, then what I sometimes use is some medication to shrink the fibroid down to that 8 to 9 size for me. And then I treat their fibroid with the Sonata. So generally, I'm saying up to maybe 11, 12, depending on how you respond to the medication to shrink it with hormones. Then I can then do Sonata for you.
Thank you. Now, this one is a long one, so I
Okay.
need you to put your gynae hot family on.
Okay. Okay.
So, Nick has gone to her consultant, okay? And her consultant was supposed to discuss options because her fibroids apparently corresponds to about 22 weeks gestation.
Okay.
She's had heavy periods for 18 years. She's had iron deficiency. She's had scans or whatnot because she has some few subserosal fibroids. The largest is 4.5 and some intramural. But when she met the consultant for the first time, he whipped out his consent form like you all do and told her to sign for a hysterectomy. He told her he would have to give her an injection on the day, and he also gave her a prescription for HRT and said, sorry, dear, that's your only option. He said they will try and keep the ovaries, otherwise it will be removed and she would have to have HRT lifelong. So her question is, does she have other options, please?
You definitely have other options. You definitely have other options. The first thing is, um, I apologize on behalf of your doctor and your gynecologist, on the fact that they didn't give you options. And yeah, I mean, that pains me. That really does pain me. But embolization would be an option for you. And myomectomy may be an option for you, depending on previous surgical history, and where the fibroids are. 22-week size uterus is not that large. You definitely have the option of a myomectomy. You have embolization as an option. And if a lot of your fibroids are submucosal, resection of them from the inside is also an option. The second thing that he or she said about they might be able to save your ovaries, that's crazy. They do not have the right to remove your ovaries if you want to hold on to your ovaries. That's crazy. Okay? Even if you decided you wanted a hysterectomy, if you wanted to keep your ovaries, they are not supposed to remove your ovaries. That's not the only option. The ovaries are not entangled into your uterus and they don't come out as a block. They are two separate organs. They can remove one and leave the other.
Thank you so much for that. So back to our advocate, advocate, advocate. You have to advocate for
Yeah.
yourself. Now you have the knowledge,
Yeah.
and this session will be hosted on our YouTube channel. Please feel free to refer to it. Write down all your options so that I
Yeah.
don't like it when my patients come with a list, but this time it is so important you have the list with you so
Yeah.
that you know what you're asking and be
Yes.
confident about it.
Yeah.
Yeah, you've done your research,
Yeah.
you have your evidence, you know what you want.
Yeah. And take
Okay,
someone with you. Take someone
I
with you.
know.
Sometimes it's
Yeah,
easier when you have someone with you advocating for you as well.
absolutely. Right. Someone talks about they were diagnosed last year, but the fibroids were about 1 to 3 centimeters and the symptoms were mild. So she's asking, does she need to treat them at all? When
Mm,
they didn't recommend anything, is there, they
yeah.
just said, oh, can we give her specifics like the type? She just wants, all she knows is that they are called leiomyomas. But
Sure.
is
Sure.
there, should she be treating? Should she leave it? What should she do?
Yeah, and that's a really good question. And there are a lot of it depends on a number of things. So it depends on your age at the moment, because if you are approaching menopause, then your fibroids are unlikely to grow much further, and so you may not need to do anything about them right now. If you're younger and you have another 20 years of hormones circulating in your body, they're likely to grow. But to be honest, we don't have the evidence about which fibroids grow and which ones don't. But we do know typically they do grow. And they start off growing quite slowly and then they get a little bit faster. The other thing to consider is, do you want a pregnancy in the future, or have you completed your family? Because if you've completed your family and they're very small, then you could potentially use something hormonal, and keep an eye on them as long as they don't become too large. But if you're younger and you want to have a pregnancy in the future and you've got a couple of them and you're black and you're likely to have multiple ones growing, I would treat them now, shrink them now, and those don't grow any further, and potentially, so that you may grow new ones in the future, but you've addressed those ones. But it depends on all those other things: the age you are, your fertility aspirations, where they are located, how many are there? Is it like two or is it like 10? All those things will determine which of those options are better for you.
Thank you, Natalie. I'm so sorry, everyone. This sounds like a session that will run over because I've got so many questions. Everybody wants to ask Natalie lots of. It's so wonderful to have a consultant that we can all just ask our questions. So apologies in advance because I have a few more questions.
Okay.
So if Olua wants to know what's the role of nutrition in fibroid management, there's a lot of information about this out there. People talk about foods that can shrink your fibroids. How true are those?
Mm.
Mm,
I can only talk about things that have the evidence behind them. Vitamin D has evidence behind it. Apart from just vitamin D, about you needing it for your health and so you're not tired, low vitamin D is associated with greater fibroid growth. So now you have a second reason to make sure that you're taking your vitamin D. Green tea extract is another thing that has been shown to help reduce the growth of fibroids. So that has evidence behind it that that you can take that to help reduce the growth. It doesn't necessarily shrink them. It does not necessarily stop new ones from coming, but the growth is slowed down. Anything beyond that does not have sufficient evidence for me to be able to recommend or say you shouldn't. If it's safe and it's not causing harm to you or causing accelerated growth, then I don't say don't try it. So if somebody says, I've heard things about beet. Beet is great. Have some beet. No problem. It's not going to harm you. And if it helps, great. So that is my position about all the rest of it. There is also a little bit of evidence about some foods having higher plant estrogens, like yam and soya, and whether we should be reducing those in our diets. Maybe. I think there's no harm in reducing it. Anti-inflammatory diets, so avoiding red meats and processed meats. I think those are also beneficial, as for general inflammatory processes in our bodies. So I say go for it. The other things, if it doesn't cause harm, go for it.
thank you so much for that. I've actually learned something. Low vitamin D, green tea. I didn't know that one. Thank you for that.
No
So we've got a
problem.
doctor joining us today, Dr. Poonam Mada. He asks if and when fibroids do increase by size year by year, what is considered the average increase rate and what is considered
Ooh.
rapid? Ooh, yeah. Doctors will always ask doctory questions.
Oh my gosh. I don't have the numbers, but I have them somewhere written down. There is an average rate. There is an average rate of size, but the rate of size also depends on the current size. So, for example, when it's quite small, like below 2 to 3 centimeters, the rate is slower. When it gets to about 5 centimeters, the rate begins to accelerate. And so we don't really have a cutoff where we say, okay, this percentage diameter growth is accelerative, but it's kind of a bit of a judgment call, though they do have numbers of what the rate of growth tends to be at a particular size, but I don't have those numbers for you. I mean, I can find them. I've got them in my documents. But basically, we tend to just go anecdotally in terms of judgment call, like somebody had a scan and it was 5 centimeters, and now it's 10 centimeters in 2 years, that's a bit fast. And then we need to do an MRI. Could this be something different? Could this be a malignancy? That sort of thing. So I don't have those numbers for you, I'm afraid. But you can drop me an email and I will find it for you.
I think we might have to put some of these questions in an email because there's a lot of them.
Okay.
Okay, so now we've got Funke who wants to ask you about the fact that she's gone through myomectomy before. They've come back now, they're about 8 or 9 centimeters. She has a combination of them in different locations. She's 48, she still wants a child. Is Sonata the best treatment for her? Because she has an appointment and she wants to go armed and ready.
I'm very pleased that you want to get that information before you go. If you've had one myomectomy, they can do a second myomectomy for you, or you can have Sonata to shrink your fibroids. Both of those are good options to address your fibroids and prepare your body for a pregnancy. In terms of pregnancy, which is not the topic of the discussion today, but you should also get your fertility evaluated and work out what you need help with in order to achieve that, so that once you get your uterus ready or address that aspect, the other aspects are also ready.
Thank you so much. Right. Sishan wants to know, can subserosal fibroids contribute to heavy bloating and stomach discomfort?
Yes, they absolutely can. So the subserosal fibroids can press on the bowel, can press on the bladder, can just cause that distension, and that pressure on the bowel will affect how the bowel is functioning and therefore retain more gas and cause more bloating. So it's the combination of the structure of the fibroid itself causing that pressure, but also the effect it's having on the bowel, that the bowel is then also then contributing to the bloating. So it can definitely do that. And did you say pain as well? You can get things like degeneration in fibroids where the blood supply changes and it can cause pain. Absolutely, those things can happen.
Okay, someone else wants to know, the waiting list is for Sonata is too long in London. What are you guys doing to reduce it? And they also want to know, if fibroids have calcification in it, can it still be ablated or can
Mhm.
other treatment be used? And can
Mhm.
a tablet dissolve that instead?
Really, really, really good questions. Okay. The long waiting list for Sonata, what are we doing about it? Well, I know that there are some high-level discussions about the funding because when NHS England changed the funding last year, it changed the affordability for different hospitals to do the Sonata. So the ones who were about to start were like, wait a minute, it's going to cost too much now. And there are discussions in the NHS England and at those high levels on the Royal College of Obs and Gynae, looking at making it more affordable. And then once it's more affordable, then we can move to advocating in the different hospitals to provide it more. And I think as more women ask for it, and the waiting list becomes longer and you shout about it a little bit more. I'm sorry, you need to help me by shouting about it a little bit more. Then they can. So I know certainly in my what we call job plan, I used to have one Sonata list every 4 weeks. And from this year, I now have two Sonata lists every month. So
Wow.
they are increasing it as we talk about it more, as we ask for it more. And so as the funding aspect gets sorted, then hospitals can provide it more. Um, yeah, so keep asking. Don't keep asking, just keep asking.
Wonderful. You've heard it. Keep asking. So, thank you, Natalie. There's someone wants to talk about fibroids and being on apixaban. Okay,
Mm.
they've been trying to find, the best way to treat it, but they are worried because she's on apixaban. There is the possibility of bleeding, and they're going to consult her hematologist. She wants her to have a hysterectomy. She's worried about the prolapse post hysterectomy. her fibroid is submucosal. So she's thinking, would Sonata be an option for her?
Yes, Sonata, as well as the resection, is an option for you with a submucosal fibroid rather than having a hysterectomy with all the complications that you can have. Absolutely. You don't even need me to answer. You've answered your own question in the middle of your question. So, yes, resection and Sonata, an option for submucosal fibroid to help you avoid a hysterectomy. I mean, yeah. I mean, you're clearly on a Pixaban for a reason, and so they would need to anticoagulate you, and to, manage that after the operation. It's complex. So yes.
Thank you. Thank you so much. Now, someone, Derek would like to know from your experience, what's the biggest factor that determines whether the fibroids will remain manageable with medication versus when it eventually requires intervention? And how do you identify that early when it's in the patient's journey?
Wow. Okay. Okay.
I know. That's why I said to you there's lots of questions.
Unfortunately, women's health gets the least amount of money funding for research. We don't know what determines whether that fibroid is going to grow and become a bigger problem later on. We need more research. And I love how Lupita and her advocacy in the United States, and she raised all this money. And so far, it's gone to two projects, one of which is about the fact that women with sickle cell disease are less likely to have fibroids. And is there something about the uterus or the conditions within sickle cell that help prevent fibroids? And then they're also looking, I forgot what the second project was, but we need more money in research. We don't know. We don't know. I'm sorry.
Thank you. Thank you so much. Now we're moving a little bit away from Sonata into Rayeko.
Yeah.
Someone wants to know, what do you think about it as a treatment option? Another person wants to know, how long should people be on Rayeko for?
Okay, so it is a treatment option for making your periods lighter when you have fibroids, 100%. A lot of women get really good benefit, makes their periods lighter. It does not shrink fibroids. I repeat myself. It does not shrink fibroids. They talk about a 10% shrinkage by volume. That's nothing. Um, but you can have some postmenopausal side effects. You can be on it long term, for months, years. But if you are on it for that length of time, they need to keep checking your bone density every year. So you have a DEXA scan to look at your bones every year to make sure that, because what Rayuko does is it stops your body from producing its own estrogen, but then gives you back a little bit of estrogen. So it makes you slightly lower estrogenic, and that can affect your bones. So you need regular bone checks to make sure your bone density is fine. What was the second part of the Rayuko
How
question?
long? How long?
Right. There we go. So you
Yeah,
can be
you
on
can.
it, it doesn't shrink the fibroids though, but it helps with symptoms. So I find it useful prior to surgery, or I use it if somebody is peri approaching menopause and does not want any HRT, and that will give them the relief until they go through their menopause. Yeah.
That is good you've said that, because I've got somebody, D's 45, has one intramural and one that is on a stock. She's
Mm,
not happy with or comfortable with being offered Rayeko. So she's
mm,
asking what minimally invasive options might work for her. Because you said that
mm.
Sonata is not suitable for fibroids on a
And
stalk. She doesn't want hysterectomy, and she's been told myomectomy is not suitable either. So
mm. Myomectomy is suitable from what I've heard. So you could have Sonata for the one in the wall, the intramural one, and you could leave the pedunculated one if it's not causing you any problems, or you can have a laparoscopic myomectomy for the pedunculated one, or a laparoscopic myomectomy for both the pedunculated one and the one in the wall. So yes, myomectomy is possible and suitable for you. Yes.
Okay. Um, Go back. Sabrina wants to know. You mentioned about Sonata being incisionless, but then you mentioned laparoscopy again for Sonata. So she's a little bit confused. Can
Confused.
you explain,
Sure.
please?
So there are a number of different types of radiofrequency ablation. Sonata is one of them, which is incisionless because it goes through the vagina, through the neck of the womb. There is another procedure called a SESA, which is laparoscopic radiofrequency ablation. It's in the United States. It is not here. So in my presentation, I was talking about the different ways we can do radiofrequency ablation, but we don't do Sonata laparoscopically. It's all done through the vagina.
Okay, so Dion said she'd had open myomectomy 1 year ago. They removed about 21 fibroids. Her periods are better, but she's noticed that they are longer. And she's been told the fibroids are growing back, like you said, and she has adenomyosis. Do you have any recommendations of where she can learn more about adenomyosis?
Hmm.
Mm.
There is a charity called Endometriosis UK, and I'm sure they have some information on adenomyosis there. And maybe if you contact Han, I can find some resources for you because I can't think of them off the top of my head, but I can find some resources for you on adenomyosis.
Right. I wish we could carry on. I am so, so, so sorry, guys. It's 12:10 now, and I'm sure Natalie's tired now. There are still some questions. So I think the best thing is if we could share Natalie's email, or if Can could collect the emails and we can share it with you, and then hopefully we can put them back on and send it back to the people that are asking the questions.
Great.
Um, I am so sorry we have to stop here. And I really thank Dr. Natalie, Dr. Miss Natalie Nunes. I have to say your name properly because this has been absolutely amazing, really wonderful to hear so much and empowering us,
Mm.
for us to go into those consultation rooms and know exactly what we're asking for. So, Natasha, I'm going to hand back to you. Can you please let people know? Because some people are asking about where they can get the slides and the video so that they can watch it, so that when they walk into that consultation room they know exactly what they're asking for and they can advocate for themselves.
Yeah.
And but honestly, Dr. Miss Natalie Nunes, that was amazing. Thank you
Thank
so
you
much.
so much. Thank you so much. Thank you for being part of this with me today. Thank you.
What an amazing session. There is never enough time. It wouldn't be enough time. Uh, Not just because Health Tower is truly a safe space for us to have these conversations, but because the need is so great. And people feel like here is a good place to ask questions. And it's not always that we have access to an expert such as yourself, Dr. Natalie. So really, thank you so much. I feel so much more knowledgeable, and my eyes have been open to technology, medicine advances. And it's really great to have this time with yourself to hear from someone that puts in very plain words what can be done. Loads of video imagery. I think we're all very, very grateful. As you can see in the chat, the praise is nonstop. In terms of the questions, please do email us at healthtower@can.org.uk. I've dropped the email in the chat. Also, the episode can always be found in other episodes with Dr. Natalie as well about fibroids, more into what fibroids are, and so on and so forth, also on the same YouTube. And I have dropped Dr. Natalie's website. So if you need to reach her, I know there was people asking about consultations, things, so on and so forth. Maybe that's a better method. But for general questions, do email Khan so we can filter it. And if needed, we send it to Dr. Natalie. Okay. And now just thank you so much. Thank you, Dr. Onyi, for your wonderful hosting, super dynamic and engaged with the chat, and with Dr. Natalie and Dr. Natalie, as always, absolute pleasure. We can't do this without you, really. I want to share some slides here. very, very succinctly about what Kana's doing and things that could be very useful to yourselves. We do this 50 weeks of the year. I think I do it 25 to 30, something like that. And Sam, my colleague that many of you know, does the others. So Health Hour next week is about gut health and digestive wellness. We'll have a awesome GP and clinical person with us, Dr. Falak K. Yusuf. And this is a very trendy topic at the moment about gut health and so on and so forth. So please don't miss this session. It will be super interesting. As you know, it's free. You just need to log on Zoom or YouTube. And as you know, Black History Month for Can is 365 days of the year, is all year round, but October is approaching fast, and we have the Black History Month Civic Lounge event in Greater Manchester. One day we'll do it in London too. We'll put it there in the universe, but is in Manchester and is supported by the Greater Manchester Combined Authority. Was something that was supported by the current PM now, Andy Berman, that really supported us in the last 3 years in making this happen. And it's nice to still have it. Again, it's a free event. Just great to connect with our community, with civic leaders and so on and so forth. So do join us. QR on the screen as always. We have a wonderful project in London. It's called Safe Steps, and it's focused on making sexual health accessible to people in Lambeth, Southwark, and Lewisham. It's particularly focused on people of Black, mixed heritage, Latin as well, backgrounds, and other minorities. So please do join us. Safe Steps is a wonderful service to use. You can use the hubs. You can speak to us via WhatsApp. You can speak to us or find other local services on Find Sexual Health. So you just need to scan the QR code on the screen, get in touch with us. And to make projects such as Safe Steps work, we do need community champions and volunteers. This is a great opportunity to gain work experience, to be a very valuable member of your community, even more than I imagine you are already. And we do support some of the expenses. Please don't refrain from getting in touch with us so you can become a community health champion with Safe Steps phone number and email on the screen. Another piece of work that we're doing in London has to do with our Enfield Black Community Forum, Health Forum. I know that we have some new sit-downs, kind of coffee mornings. They happen every Tuesday in Edmonton Green Library. This again is in London. Please do join us. Contact us on the screen if you want to know more. Back to Manchester, because Candace work all over the country. We have the Empowered Voices panel that is coming up on the 13th of August. This is an in-person event. It is focused on people that have been victims of domestic violence. We have called the Empowered Voices panel because we wanted to move from victims to being empowered. This is a safe space for conversation, changing tips on practical self-care and other guided activities that will happen on the day. Also, a number of great speakers. Again, free event. We do this for our community, and we do believe that the social determinants of health are very, very important. And this is why we do work in other areas. Okay, last but not least, touching on that subject of social determinants of health, we have an ongoing project right now helping people that might be due Windrush compensation. So we are deploying free confidential one-to-one support for anyone in the Northwest applying to the Windrush compensation scheme. You might not know that you are entitled, but you think you are, get in touch with us. We can help you find these answers. If you have received no's or you found the process difficult, we can help you. We have a team that is ready to help. And guess what? Again, it is free of charge because it's already funded by the UK government at the moment. So thank you so much for today. I know there was a lot of information, but it's all for you, just like Health Tower. And I look forward to see you next week. Bye-bye.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.